Hi, I'm Ray, and welcome to this live webinar, which is a bit of an introduction on one of the educational topics that are going to be featured at this PESI upcoming obstetric summit. So yeah, my name's Kathy Fray and I'm a midwife. And if you're wondering what this accent is, I'm a Kiwi, I'm a New Zealander. Our accent often gets confused with Australians. And for us, Australians sound quite different. They're a lot more twangy, but in New Zealand tends to be a little bit softer, maybe a little bit more British sounding. But yeah, so welcome along. And I'm going to be highlighting a workshop webinar that we're going to be educating on about becoming motherwise, or avoiding the cascade of intervention and understanding the cascade of normalcy in labour and birth. Yeah, so where are you tuning in from? Oh, yes, so tuning in from New Zealand. I happen to have been New Zealand's #1 best-selling birth, baby, motherhood author since 2005. Although these days, most of what I'm doing tends to be more international work like this. Yeah, so we have, I think you've got some questions for me? Aha, okay. So I work with mothers who have previously had an induced labour, and how do we encourage them to wait out their current labour process? Well, okay. Inductions should only ever be done when they are strongly medically indicated. I mean, that's the bottom line. We should not be willy-nilly, as they say, just, go, oh, we might as well induce you today. No. Absolutely, statistically, beyond any shadow of a doubt whatsoever, the safest labour for the mother and birth for the mother, and the safest labour and the safest birth for the baby is when we have not intervened. Okay, so to give you the main things that statistically drastically increase are instrumental deliveries, that's forceps and ventouse, surgical deliveries, so that's C-sections, hemorrhage rates, women being admitted into ICU or HTU after giving birth. So those four things drastically increase when we intervene in the labour process. And the very first thing that we intervene with is inducing or augmenting that labour. Inducing is when a woman is not in labour at all, and she medicine drugs are used to induce her womb to start contracting. Augmenting a labour is when a woman is already in some level, typically late in early labour, and drugs again are used to speed things along. So inducing or augmenting, which generally is an oxytocin drip, or in America that's often called Pitocin, or it's syntamitrine, oxytocin, it's all the same kit and caboodle, really. But there's an oxytocin or Pitocin drip that's going along, which is forcing that woman's womb to contract. So the side effects for the babies are statistically is lower APGAR scores. Now, the APGAR score is a score that's done on the baby's wellness at 1 minute and 5 minutes. So you've got lower APGAR scores on the baby. You've got much higher rates of admission into SCBU or NICU for that baby. So those are the two big things that happen for the baby. We just have traumatized babies arriving. So, and there's going to be a consequence of that trauma. And we have obviously traumatized women as well. So going back to the question of a woman who's may have had a history of being induced, and she's sort of wondering what to do. Well, the first thing is going back to the basics of we should not be inducing unless the woman, it's strongly medically indicated. And when you look at the reasons that it can be strongly medically indicated, we're talking about a woman, say, who has fulminating, that's rapidly escalating preeclamptic toxemia. So she every day is getting more seriously unwell, and the fix for that is for that baby to be born. And so they will induce her labour at that situation. That makes complete medical sense. But not, there's so many other reasons that are used as practically excuses, and they're absolutely not a valid reason. So the safest thing is for that woman to be able to spontaneously, naturally go into labour, and maintain a naturally spontaneous labour. It's the safest thing for her, and it's the safest thing for her baby. Now, during the webinar, the actual formal education workshop that I'll be doing with Pessy, we go into a lot more detail on this. So today is just a little overview, but we're going to really go through medically the ins and outs of what occurs during that cascade of intervention, and what occurs during the cascade of normalcy, which is when you don't intervene. And very few things go wrong at that point. We've got a little message come in. How might we support all couples and donors to be at healthy weights and optimal health prior to conception? Preconception health is a whole topic in itself. But the more that I'm sorry, you threw up another question there. Can you put it back up? Oh, no, just there. How might we? Okay. Sorry, it's in both places. Thank you. Preconception healthcare is a whole topic in itself. But basically, the more that we study, the more that we are realizing what the impact of epigenetics. Now, epigenetics is the health before conceiving, and what we're realizing is that optimally, the male partner who's producing the sperm should be doing 3 to 6 months of preconception healthcare, and the female partner who's contributing the egg ideally should be doing 6 to 12 months of preconception healthcare. As far as how can we help someone have a healthy weight, that's a whole. I think we can all answer that one just from common sense, that we need to inspire women to be at a healthy BMI. Although I would question that. I would actually personally question that the idea of somewhere between sort of 19, 20 to 24, 25 is optimal for for fertility. I don't think that's quite right. I think that it's a little bit more meat on the bones is healthy for falling pregnant. So I would say it's probably more around the BMI of sort of 22, 23 through to 27, 28, somewhere in there, just a little bit more meat on the bones, because the body wants to know that if you fell pregnant and you were because remember, our bodies have not changed very much from when we were prehistoric man and cavemen, cavewoman. Okay, we haven't really changed. Our bodies haven't changed much. So the body wants to know, to successfully establish the pregnancy, that if during the pregnancy you were to face some periods of starvation or some malnutrition, and you weren't able to eat so well for a month or two, that there's still enough meat on the bones to continue that pregnancy. But certainly, if a woman who have a high BMI, especially from 35, a BMI of 35 or more, that does impact fertility as well. And it certainly impacts the chances of having a complication in pregnancy, particularly gestational diabetes and preeclamptic toxemia, which obviously impact fetal health as well. So going back to the 3 to 6 months of preconception health care for the man, and 6 to 12 months for the woman. We'll be going into a bit more detail on that. But generally, it's about, that's the time period is required for the male to produce the healthiest possible sperm, and for the female to produce the healthiest possible egg. And it will also assist her body to produce the optimal womb lining. So it's making them as a couple the most fertile that they can be. And not just the most fertile to conceive, but also the most fertile for the pregnancy to successfully establish. There is a general misunderstanding by women, by society, that as soon as she's pregnant, apologies to not wishing to offend any in our LGBTQ community by saying she, but we're just being very generic, seeing as we're talking of pregnancy. But basically, as soon as those with the female genitalia are pregnant, they assume that the establishment of the pregnancy succeeding is now all down to them and their body. And that's not true. It's also at that point still very relevant about the quality of the sperm. Generally speaking, to put it into perspective, around about 70% of eggs that are fertilized never implant. And of those 30% that implant, around about 1/3 of those never continue to establish as a successful pregnancy. So that means that about 2 out of 10 or 1 out of 5 fertilized eggs translates into a successful pregnancy. That's normal. And so it's normal that about 1/3 of pregnancies naturally miscarry. What's not normal is when women are having recurrent miscarriages of sort of, say, 2 or 3 miscarriages in a row. That's not normal. There's something else going on. Generally, it's about 40% sperm related, about 40% egg or female body related, about 10% both, and about 10% unknown. But, oh, I'm so sorry. Get rid of that noise. So that's where preconception healthcare comes in, where the couple are taking supplements to ensure the highest quality egg, highest quality sperm. So we have really digressed off the topic of the cascade of intervention, but that's all good. It's all fine. So throw up another question. Yeah, cascade of intervention. So the cascade of intervention is basically in the process of labor. When you do one thing, it leads to the next thing needing to be done, that leads to the next consequence, to the next consequence, to the next consequence, to the next consequence. That's the cascade of intervention. So as soon as you start to induce somebody and you've got an oxytocin drip going up, the next thing, if it hasn't already been done, the next thing that's going to occur is a need for an epidural. Because when you put an oxytocin drip up on that person, you've got continuous monitoring going on of the fetal heart, because you have basically turned them from being low risk in labor to high risk in labor. So because they're high risk in labor, that's high risk of the baby becoming stressed, or the pregnant, or lots of other complications, but that's the commonest one. And why would the baby become stressed? Because you're pumping in oxytocin to force that womb to contract, and it makes more fierce contractions than natural contractions. So consequently, the woman needs the freaking epidural because she's stuck on a bed with this continuous monitoring belts around her. She can't move properly, and she can't move properly to cope with those oxytocin contractions that are going on. They're just not the same as natural contractions. Not to say that natural contractions aren't painful, but it's a different kind of pain. So the oxytocin drip combined with the epidural, pain relief and analgesia, that's the combo that then creates this ongoing combination of all these other things that happen. And we will go into great detail on that. But the commonest outcomes of the complications are either fetal distress or failure to progress. So either the woman doesn't fully dilate, or she gets fully dilated and she can't push the baby out successfully, or the baby will get stressed during the process. And then the baby needs to be yanked out, cut out, or sucked out. So blunt, but that's what happens. And if we go on to the next question, I think we've got another one coming up. Yeah. I am a nurse in labour and delivery. How do I change the culture in my hospital setting? Yeah, it's a tricky one, right? It's not just about it's not just about persuading people to stop inducing unnecessarily or augmenting labours unnecessarily, and then hey presto, woman won't need an epidural and everything's fixed. Unfortunately, it's not that simple. Woman, if we go back decades and easily 100 years, it was absolutely normal that women attended women in labour and birth. It was not the domain of men, and that there's nothing wrong with a male partner being there. I'm not criticising it, but the point was that women attended women, and typically by the time, and most births happened at home. And by the time a woman was pregnant herself and going to be facing her own labour, she had attended so many births. She had already seen what it looks like, what it sounds like, what it feels like, how tough it looks, how miraculously amazing it is as soon as that baby's born. She'd seen all of this. Whereas these days, for the male partners, well, clearly they've never given birth. So, it's wonderful to have them there as a support person, but they don't come with experience, right? And they've never done it themselves, and probably highly unlikely to have attended a labour or looked after a woman giving birth before. So our main birth support person has zero experience. And the woman herself, for most women these days, when they go into labour, their labour is the very first labour they've ever been at. What do they know? They've attended a few classes, and perhaps buried their head in the sand a little bit. And as soon as they were pregnant, went, yeah, line me up for the epidural. I'm not doing that naturally. And all this. And then we're also in this situation of the birth horror story, where through social media, particularly, women are talking about the trauma and things like that. Like we've kind of lost sight of natural and normal in a lot of ways. Particularly, I would have to say, in America, it's pretty horrific. The statistics in America are the worst in the world of a developed country for your birth outcomes of maternal and fetal morbidity and mortality. I mean, they're the worst in the world, and they're the worst in the Western world. And some are questioning why, but not a lot. So going back to the question of, hey, if you're a midwife on birthing suite, what can you do? One of the first things that you could do is become really knowledgeable on homeopathy, on the use of homeopathy in labour and birth. Because when if you're a shift working midwife, and you come in, you've got 8 hours or 12 hours to make an impact, and you're gone again. And you could come in looking after a woman who's already been there for hours. You might finish off your birth, and then you start looking after another woman, and then you're off your shift and it's gone. So it's very, very challenging for shift working midwives to make an impact. Certainly, self-employed caseloading midwives have the opportunity to have a much larger impact. And those midwives tend to already be very holistically minded. That's where they're heading down. They're all about normal and natural. But if you're a hospital working midwife, you are exposed to far more medicalized situations. And so the two things actually I would say you could do, actually three things. One, learn about using homeopathy during labor and birth, because it's a very complementary medicine that can be used completely safely alongside anything else that's being done as well. And it works very much on helping the woman's mindset as well. So a few little tinctures of bottles in your pockets, of your scrub, and you can become the midwife who's known on Birthing Suite to always use homeopathy. And some people will rubbish you, and let them rubbish you. They'll tell you it's a pseudo medicine and it does nothing. And you'll go, well, if it does nothing, no harm in using it then, eh? So yeah, that would be, because that is something that you can use. It's and it can become part of your practice, and you can be the one that's standing up and questioning. And when it's something, why are we inducing? Why are we augmenting? Particularly if you're a charge midwife, if you're a senior midwife on that ward, you should be questioning that anyway. It's difficult for the more junior midwives to question senior midwives or obstetricians. But if you're senior, you should definitely be going, why are we augmenting this woman? Why aren't we just sending her home and let her establish naturally into labour, and then bringing her in when she is having 3 to 4 contractions every 10 minutes, all over a minute long that she can't talk through? Then she's established into labour. Why are we inducing this woman? What? Because she's post-dates. She's 41 weeks in one day. That's not post-dates. 42 weeks is post-dates. Go home. Walk around the block multiple times, see if you have a lot of sex, see if you can get yourself into labour, and come back in a few days' time. So it's about questioning things and taking charge. The other two things I think that as a shift working midwife you can do is, one, engage in the Motherwise.app. So that's just www.motherwise.app. So motherwise.app. And you can go on there and use that as part of your optional education as well, after you've done the PESI stuff, and just supplement that information, Yep, that'll be fine. Throw that question up. Sorry, I just got a little private chat here. That's all good. And then the third thing that you could be doing is actually spending some time as a midwife with a case loading, holistically practicing midwife who does lots of home births. So refresh yourself. Like, get back out there and see real and see normal, and see natural again. I have been in situations where of mentoring American midwives in their final 3 months of clinical practice, where they've come to New Zealand to do that, so that they can see normal and natural. And you want to do that equivalent, but maybe you don't need to fly all the way to New Zealand. And get yourself back and go and volunteer at a birth centre, for a little bit. Just get yourself back seeing normal and natural. Okay, so I think we've got another question coming up. Is there a relationship between epidurals and breastfeeding success? Yeah, there is. And it's not directly from the epidural, but then again, you could say it is. What it is it's what happens from that epidural. So when you've got an epidural and you've got a significantly higher chance of that leading on to a traumatic or dramatic delivery, instrumentally vaginal delivery of von twos to forceps, or cesarean delivery surgically. When you've got those traumas happening to the mother and the baby, then her recovery can be quite horrendous, and certainly the baby's recovery too. And that directly impacts the ability for that baby and that mother to form a beautiful synchronicity of breastfeeding. And just a reminder again, I know you can see the information up there, but yeah, we've got this obstetric summit coming up. The speakers that are coming to that are amazing. So you definitely want to be part of that if you are out there as a birth practitioner in any capacity, be it midwife, doula, or obstetrician. If you're dealing with maternity health, this is one for you. So yeah, when you if we look at it from the woman's perspective, a labour is generally the calorie equivalent, approximately, of a woman of doing a marathon. Okay, so by the time a woman has been through a labour, generally that's been a marathon on her body. And so what are we going to do after that? Oh, okay, she's had an epidural, the baby's malpositioned, the head's not well flexed, all these details we're going to go into on the webinar. It's asynclitic, it's malpresenting, and the baby's now got fetal distress, and she needs to go for this emergency section. Oh, we'll try and do an instrumental delivery first. Oh, that's a failure. So now she's got an episiotomy for that as well, and that's failed. So now she's off to surgery, and to have this dramatic C-section because the baby's having prolonged decels, late decels that are very concerning. And the baby needs to be delivered within the next 10 minutes, please. 5 minutes preferably. Okay, so all that's gone on. So you've got this traumatized, shocked baby that comes out, and you can really see it on them. I mean, they are shocked. And they're like a stunned mullet. I don't know if you know that term in America. A mullet is a fish. But they're stunned. They look stunned. They look shocked. And nobody's going to tell you that, by the way, as a mother. They're not going to go, oh, yes, we've got the baby over here at the resuscitator. It's very stunned and shocked at the moment. We'll see if we can help it get some better ABGAR scores on its fifth minute 5. No one's going to tell you that. They're going to say, oh, yeah, it's all good. It's all good. The baby's on. Of course they're going to say that because fingers crossed, this baby will be fine of its shocked state. And so then, especially if they've had either a lot of ramming into the pelvis and they've got this cone head, some form of, it is normal for babies' heads to mold a little bit, but there's excessive molding as well, which can lead to, and they get these Kefal hematomas, which are these massive bruises on their head, so they can get that, or they can have marks, this great big chignon, we call it, which is a French name for a bun, this great big chignon that can be on the back of their heads from the ventouse that suck them out. Or they can have these forceps marks on their head, sometimes in some really weird places, depending on the asyncliticness of that baby. And so that baby's going to be yanked out, and somehow it needs to breastfeed. It's got a headache. And the mother has just gone through the marathon with major abdominal surgery. And then we've handed her a baby and said, hey, feed this every couple of hours. In what situation do we ever have a person who runs a marathon and then immediately follows that with major abdominal surgery, and then we give them a wee human being to feed every couple of hours? It's a level of insanity gone crazy. So that's why it will, of course, impact the breastfeeding. How can it not? It's going to impact the baby's ability to latch, and it's going to affect the woman's ability to cope with it all. And that's so different to when you see a lovely, natural, normal birth, and the baby just is placed on the woman's chest, and they naturally will squirm their way up and just naturally latch themselves onto the nipple beautifully, stunningly, almost 100% perfect every time. And what an amazingly different experience that is. So look, we're going to wrap it up here, and hopefully this has been an interesting taste, but we are going to be going into it, as I say, a lot more detail so that you feel empowered to understand that cascade and how one thing leads to the next and how this impacts that, and that cascade of normalcy where one thing impacts the other. Because when you understand the flow of labour, then it makes it you better able to, well, direct it, I guess, and keep things on track rather than sending it off in other various directions. So anyway, look, thanks for your time, those who were here live today, and we wish everybody a wonderful rest of your day, and hope to see you at the upcoming PC webinar. So bye, everybody.